Good afternoon, everyone. Welcome to our webinar. Before we begin, I want to start with a land acknowledgement. So each day, probably like you, I walk my neighborhood. I especially like to walk in the woods nearby. It's easy to think that the forest is still and quiet, but I find that if I stop, if I am still, and if I listen, I realize just how much is going on around. I realize how much there is to learn. And I am reminded that if this incredibly rich, complex, diverse community can work together, then surely so must we. I invite each of you to take a moment in your day today to stand and face the sun and humbly reflect on the truth that Ottawa is built on the unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived in this territory for millennia. Their rich culture and presence have nurtured and continue to nurture this beautiful land. We would like to honor the peoples and the land of the Algonquin Anishinaabe Nation. We would also like to honor all First Nations, Inuit, and Métis peoples, their elders, their ancestors, and their valuable past and present contributions to this beautiful land. My name is Michelle James, and I'm the coordinator for the Ottawa Black Mental Health Coalition. Through my work with the coalition and the various working groups that I participate in, I've had the opportunity to work and collaborate with many groups, and including the paramedics that are here in Ottawa. And I have so much respect for the work that paramedics do in the community, often in very challenging situations. So I'm very excited to be facilitating today. On behalf of the co-sponsors of this event, the Ottawa Black Mental Health Coalition, Minawashon Lodge, Ottawa Community Partnership for Health Equity, Crime Prevention Ottawa, and the Social Planning Council of Ottawa, I welcome you to our 6th segment of this webinar series, Responding to Mental Health Crises, Learning from Models in Ottawa and Beyond. So in this session, we are continuing our learning journey on the topic of mental health crisis responses. It's really important to note that Black and Indigenous communities have historically been underserved and often inappropriately served by mental health services. Not having good options for mental health crisis response is sadly a matter of life and death. It is our hope that by showcasing some of the existing responses and options, both here and abroad, we as a society can continue to learn how we can do better to serve some of our most marginalized families, friends, and neighbors. We must work together to end racism. Following George Floyd's murder, communities across North America have been looking for better ways of responding to people in mental health crisis. So I'm very excited because to tell us about their way of responding to crisis in their community, I'd like to welcome our speakers. So today we are very lucky to have Marty Mako, who is the commander of Mobile Integrated Health with Niagara EMS. He is responsible for the design, development, implementation, and evaluation of their clinical MIH programs. He collaborates with both internal and external healthcare stakeholders and thus ensures the clinical, operational, and financial goals of the organization are being met. Previously, Marty was a manager in the Chronic Disease and Injury Prevention Division of Niagara Region Public Health and a health promoter with public health for 12 years. Academically, Marty has a bachelor's degree in kinesiology from McMaster University and a master's in business administration. Also with us today, Leanne Pocknell is a registered nurse, graduated from McMaster University. She works with the mental health team at Welland McMaster Family Health Team and also works for Niagara EMS as part of the MHR team. Leanne was one of the founding members of MHR and the MIH model of care in Niagara, and she was also instrumental in helping with its initial design and evolution since the launch in 2018. So I'm so pleased to welcome you both here today, and without further ado, take it away. The floor is yours.
Thank you, Michelle, for the invitation to join you virtually today. We're here in the beautiful Niagara region. It's just looking out my window, 20 degrees and sunny today. You know, I love Zoom, but I would have appreciated a physical invite. I haven't been to Ottawa in a while. I know it's a beautiful part of Ontario and Canada, and I do miss the days when we'd actually have these face-to-face interactions, but we're still in a pandemic, so virtual it is, and we're happy to interact with all of you virtually this afternoon. We have a bit of a presentation we're going to share with you today. So I will start with my screen share and pull up the presentation. I am going to start by presenting a bit about of our program and our history and the development. And then Leanne is going to step in and share some patient stories to talk about on the ground what this work looks like as we respond to mental health emergencies in the Niagara region. It's a bit of a long title. I remember, I think it was Mark Twain who said, if I had more time, I would have wrote a shorter novel. Well, maybe if I had a bit more time, I would have had a shorter title for this presentation. But I decided to title it today, Addressing Mental Health Emergencies with a Mobile Integrated Health Approach. Some of you might not be familiar with that terminology, mobile integrated health. So before I get into specifically our MHR team, our mental health and addictions response team, I'd like to situate it within our overall MIH approach to care. Because when many people think of emergency medical services and an EMS response, you tend to think of ambulances, lights and sirens flying down the street to those high acuity medical emergencies. And that is still our core primary mandate within EMS. However, the nature of emergencies has changed. We're going to be talking about mental health this afternoon, but more broadly, the reasons people are calling 911 for emergency help has really changed over the past 10 or 15 years. This is a quote I like to start with from one of the fathers of EMS. As EMS providers, we invite the public to literally trust us with their lives. We advise the public that during a medical emergency, they should rely upon our organization and not any other. We even suggest that it is safer to count on us than the resources of one's own family and friends. We had better be right. And I agree with that. We had better be right. And so how we respond to these medical emergencies needs to evolve and change as the nature of those medical emergencies themselves evolve and change. I'd like to talk to you just for a minute about the last decade in Niagara, because the nature and sort of the larger healthcare system really has evolved and changed. We've had some new hospitals open in the Niagara region. We've also had the emergency departments in a few of our smaller municipalities close, and the EDs in those buildings have transitioned into urgent care centers. That has impacted Niagara EMS because our role in conveying people from their homes to the nearest ED has influenced our response times by having to bring them to different communities for emergency care. We've also seen call volume increases, significant ones. I'm going to get into that into a subsequent slide, but the overall volume of call volume has significantly increased over the past 10 years. This has resulted in us having to return to our regional council, who we report to, 12 times over a 3-year period because of this demand on our system resources to request funding for additional ambulances to be put on the road, purely due to call volume and trying to be there when our community needs us. In response to that, our council asked us to perform 3 external system reviews to look at what are those drivers behind this increased call volume, to see if we can't learn more about why this is happening and how we might have a bit of a different response. One other phenomenon, which I don't think is unique to Niagara, you might be facing this in Ottawa as well, is the concept of offload delays or transfer of care. If you're not familiar with this term, this happens when we bring patients to hospital, but the hospital is not ready to accept the patient. So paramedics are stuck at the hospital waiting to offload that patient. And we've had situations recently in Niagara where 10 or more ambulances are stuck in the ambulance bays at our hospitals waiting to offload those patients. And obviously, when you're stuck at the hospital, you're not back on the road ready to respond to the next emergency. So this has broader healthcare system impacts, as well as just impacts on our EMS service. And the reason I included both articles there was to show this has been happening for a long time. The top article there was from 2007, and then the bottom one more recently from 2018, just to show despite numerous attempts at change and ways to do things better, the problem has persisted. This slide looks at call volumes specifically, and just so you get a sense of the raw numbers that we're talking about, in the first half of the decade from 2011 to about 2016-17, you can see the increase from just over 40,000 calls a year, trending towards just over 60,000. Well, some of the consultants we brought in said, if you do nothing, you can look at one of the projections there from a company called Pomax, forecasting out over the next decade was trending towards over 100,000 calls a year. That would be all doubling our current call volume. That would be if we did nothing, but just to give you a sense of the scope of the problem with increasing call volumes to Niagara EMS. So what did we do about it? Well, we were challenged by our decision makers to really dive deeper into the local data for the Niagara region to see what is accounting for this call volume. Is it specific cohorts of patients? And is it specific chief complaints that they're calling about that's driving this increase? And what did we learn? Well, we learned in particular there are two distinct age cohorts that were driving this increase. One was older adults. So you can see here some of the peaking with late 70s into late 80s. The other was young adults. You can see from the late teens into 20s and 30s, quite a significant increase. So we found that interesting, that those were the two primary age cohorts that were driving the increase in call volume. So what were they calling about? We did some analysis into the data of complaints and why people were calling 911, and a few distinct themes stood out from the data. In that younger adult cohort, the chief complaint was largely behavioral and related to psychiatric symptoms. That is obviously mental health. So mental health related concerns in that younger age cohort stood out as something we needed to look at. In the older age cohort, musculoskeletal trauma and general illness and weakness stood out. And you might have this aging phenomenon in the Ottawa region as well. That is related to seniors who are fallen. So I've fallen and I can't get up. Not necessarily requiring a hospital transport, but what we call in the EMS business, the lift assist, where they often do just need help up. And they're calling 911 very frequently for those issues. So those were two of the issues, or I should say three of the issues that really stood out with young people, mental health conditions and concerns. With the older cohort, it was falls and just general low acuity illness and weakness that's not necessarily appropriate for an emergency department, probably more appropriate for a primary care office, walk-in clinic, urgent care center, but they're calling 911. So to the patient who's calling, it is an emergency. This is or I should say was the current patient journey prior to the system transformation that we undertook in Niagara EMS. When people tend to think of EMS, they think of calling 911. Someone on dispatch answers the phone in our communications center. They dispatch an ambulance who responds with 2 paramedics and they bring you to hospital. The old line is you call, we haul. That had been the way EMS services had operated for a very long time. But we had to ask ourselves the question, is there a better way? Is there a better way to provide care? Just because you've been doing something a certain way for a number of years doesn't mean there's not a better way. So we did quite a bit of research based on all of this evidence and data we were learning. We did an environmental scan globally of programs within the other EMS services who had made changes. And we found one in England, in Wales, actually, that really stood out. And this is a quote from one of their leaders. Central to each country's vision is the concept of providing pre-hospital care as a system rather than just as a single service type that can provide a flexible response to meet patient needs with other related healthcare providers. So this speaks more to partnerships, to collaboration, to working together as a local healthcare community to meet patient needs, which is quite a change from another organizations who typically exist in silos and follow their own mandate, but without that integral collaboration. So that really spoke to us as a better way of doing business. So we undertook this process of redefining the patient journey to look at those present healthcare system challenges that I mentioned on the previous slides and look at how could we provide the patient not just with the fastest way to bring them to hospital, but what is the right care at the right time given by the right healthcare provider? What does that really look like? And how could we be part of the solution, but more in a collaborative environment with other partners in our local Niagara region? Just wanted to mention the different elements of this broader Niagara EMS system transformation because it did have multiple components and was very complex. One component involved revisiting our 911 response policies. So just looking at what are the different reasons that we respond to 911 and what were the policies behind those types of responses. This led to the development of an evidence-based clinical response plan. So how we respond to 911 calls based on clinical evidence of what best meets patient needs and improves patient outcomes is not always about getting there the fastest. Obviously, for the high acuity medical emergencies, sudden cardiac arrest, choking, motor vehicle accidents with severe blood loss, those are the times when seconds and minutes count, and you need to be there as quickly as possible. Many people would be surprised to know that only makes up about 12% of our EMS calls in the Niagara region. The vast majority are of those lower acuity nature, where it is more about getting the patient the right care that they need, not necessarily the fastest care. So we brought in a new team of emergency communications nurses into our dispatch center. And what they do is perform a secondary triage on specific 911 calls that are not those high acuity time sensitive emergencies, but the lower acuity ones to better tease out from a medical perspective, what does the patient need? Is it referral to another community organization? Is it an appointment with their own primary care doctor? Maybe they need to visit a walk-in clinic or an urgent care center. But that way they're getting their questions answered and triaged by a local ECN, as we call them, that can better give them the direction and support that they need. Next, I'm going to talk about our mobile integrated health teams, and this is where our MHR, our mental health specific response team, is situated. So I'll get into the different MIH response teams in just a minute. And we've also looked at alternative transport and destination options. I mentioned earlier about the busyness and the volume in our emergency departments right now. Well, many times it's emergency departments are not the ideal destination for the patient. So we've been exploring other types of options where patients can get the care they need. Quick summary here of the different ways that someone can interact with us. So activated via 911 are what we call unscheduled healthcare. So those higher acuity emergencies are the ones I mentioned earlier, sudden cardiac arrest, choking. That's where we need to get someone help via an ambulance as quickly as possible. For those lower acuity non-emergencies, that's where we perform the secondary triage via the emergency communications nurses, and then we dispatch our mobile integrated health teams of paramedics. Then we also have under scheduled healthcare community paramedicine programs. So you might have these in the Ottawa region as well. This is where we have specific focused cohorts of patients that we roster onto a program, and we do scheduled home visits with those cohorts. They're often high users of the healthcare system or of the 911 system, but we don't wait for them to call 911. We proactively home visit. Provide home visits with community paramedics. So I share this slide just so you can see the difference between how patients engage with us via unscheduled healthcare through 911 or through scheduled healthcare through our community paramedic programs. So getting to what I think many of you are most interested in through our mobile integrated health team approach, through our system transformation, we created these teams, which are very intentional to address those call volume increases that we were seeing from seniors who are falling and young people related to mental health and addictions related issues. So focusing on mental health specifically, we created a mental health and addictions response team known as MHART. This involves a paramedic being teamed up with a mental health nurse, who you're going to hear from shortly. She's on the call with me. We have a FIT team, also known as a falls intervention team, where we have a paramedic teamed up with an occupational therapist, and they respond in real time to low acuity falls. And we also have a care team known as Community Assessment and Referral Team. Those are paramedics who respond to general low acuity calls in the community, and they often make referrals and connections to local partners such as primary care or walk-in clinics or home and community care to better meet those patient needs. So those were all brand new teams that came out of our system transformation. And then our community paramedicine programs, as I mentioned, those are the paramedics who provide service to rostered patients, such as those who are high volume users of our EMS and emergency department. Quick snapshot of what the workflow looks like when these teams arrive on scene. So they are activated via 911 call. So you cannot refer directly to our mental health and addictions response team. They are activated by the patient calling 911 first. That call is assigned to dispatch, and then based on either our clinical response plan or the MIH team members who are monitoring calls, they can self-assign to calls based on the call details. They would then arrive at a call. Once they arrive on scene, the paramedic does their ALS assessment first and any other diagnostic. If they decide that hospital transport is not required and the patient signs what's called a patient refusal form, basically stating they do not wish to be transported to hospital, then we can initiate our mobile integrated health stream of care. So this is where the mental health nurse, the occupational therapist, all of their roles come into play, because we're establishing the healthcare plan, which can include additional assessments by the mental health nurse. It could include referrals to alternative healthcare services, such as many of the options listed on the slide, or it could involve transportation options to other destinations via either the ERV that they drive, other private transportation options they might have, or the ambulance if it's needed. And finally here, before I get into some more details about MHART specifically, we have been trying to share this model provincially and nationally, because it is quite a change for EMS services who have been doing the traditional model for many, many years. So we have been trying to educate others and do presentations to other services who might be interested in adopting a mobile integrated health approach within their EMS services as well. So getting to our mental health and addictions response team specifically, it was formed in 2018. I'll start on the left-hand side of the slide there. As part of our system transformation efforts, which I've mentioned, and as part of the three teams, the MHART team, the FIT team, and the care team. What was really unique, and what I think one of my favorite parts of the program, is that it was developed as a partnership. So I did speak about the importance of partnerships and collaboration. With our MHART team, the EMS service, we provide the paramedics and the vehicles, and the mental health nurses are provided by three of our community partner organizations. So Niagara Health, which is the hospital system in Niagara, Welland McMaster Family Health Team, and our Quest Community Health Center. So all three of those organizations offer the mental health nurse to the MHART team. Together, they do respond to 911 calls in a marked Niagara EMS SUV, and the goal is to better address the demand for low acuity mental health and addictions challenges in real time. Currently, if you're curious about our staffing, we have one of these MHART teams. They have to cover the entire Niagara region, which is a large task. We are a very broad, diverse region. If you're not familiar, we have 12 regional municipalities and 450,000 residents, and they operate 7 days a week, 12 hours a day between 9:30 a.m. and 9:30 p.m. A few of the objectives of the program are on the right-hand side of the slide. They respond to low acuity patients in psychological distress and with the goal of aligning them with community resources that best meet their needs. So to ovide unnecessary transports to ED. They can also respond to active overdose calls and follow up with post overdose patients, encouraging addiction treatment and providing referrals to more appropriate community-based resources wherever possible, with a focus on harm reduction guidance and materials. One of the broader goals, though, is to help reduce the stigma associated with mental health and substance misuse by providing this enhanced mental health response to 911 calls. And that does create an opportunity for us to work more closely with our police service as well. Really, why I have this in italics is to ensure mental health is treated primarily as a health and medical issue and not as a criminal issue. So that really is one of the more broader goals of our program. For those of you that might be interested in the data and the evidence, since we've started evaluating the success of this program, we've seen almost a 7% decrease in transports of mental health patients to the hospital emergency department, despite an over 8% increase in the number of mental health related 911 calls. What that means is that these patients are able to access real-time alternatives and more appropriate health care. So we might not be able to decrease the number of mental health calls coming in to our center, but we are able to change our response. And by reducing the amount of transports to hospital, hopefully we're able to better meet the patient needs and get them the right care at the right time. Finally, referrals being a key part of this program. We've had over 3,000 referrals made to various community health and social services, and over 350 naloxone kits have been distributed since the onset and launch of the MHR program. Well, I think that's enough from me for now. At this point, I would like to invite my colleague Leanne, who is one of the mental health nurses as part of the MHR team, to come on the line here and share a couple of patient stories. Some of you might be more interested in the high level information. Some of you might be more interested in what does a day in the life look like. So Leanne, I'll invite you to unmute now and share a couple of our MHR patient stories. And after that, we can open up the floor to questions.
Thanks, Marty, for that. Is that a picture of me and Rob that's being shown on the screen there?
Maybe I should ask for your approval before sharing that. I found it on this place called Google.
Oh, of course. So that was the early days, actually, of us going on the streets to just really to talk to people and let them know what kind of program was going on with Niagara EMS. So obviously, we look a little different now. We're much more paramedic looking, I guess. Mm-hmm. Anyways, thanks a lot for having me come to share some stories. It's been really exciting being part of this since 2018, since the inception of it. I'll give you a little background about myself. I've worked in mental health and addictions for just over 20 years. I started in the HIV and AIDS world for a few years, and I went back to school and got a nursing degree. I worked in public health in a case management model with mental health. Then we developed an early intervention in psychosis program at public health. And I also worked with the ACT team. So I worked with people from the beginning of their mental health into it becoming more of a chronic issue. And I also worked under the COAST model, which is a police officer in plain clothes. And we were not in a police vehicle, but we went to do mental health assessments on patients in the community. So when I found out that EMS was going to look at pairing myself with a paramedic, it was really exciting because I know historically what has happened is somebody's called 911, they've got the ambulance and police maybe showing up. Sometimes there was handcuffs. Sometimes they just went in the back of the ambulance and then they took them to the hospital. And what happened? They were held in the hospital for 24, 48, 72 hours, maybe given medication, maybe not, and sent off with no discharge plan, only for somebody to either call 911 on them again, or them end up back in the hospital in that same circle. So this was really an opportunity for us to at times look for an alternative way to serve mental health patients. So, when we started out on the street, it was really watching the calls that were coming into 911. A lot of like suicidal ideation calls, family calling saying, my daughter, my son, my partner, whoever is suicidal. And those were kind of the calls we were trying to figure out if we could be effective. So it wasn't about going into a call, getting out of that call quickly and getting somebody off to the hospital. It was really sort of hashing out what is going on. So, the skills that the mental health nurse is coming into that call with is around suicide intervention, risk assessments, safety planning, history, obviously medication side effects. Can we talk to family doctors? Can we call psychiatry? Can we get other places involved that's really going to treat the patient for their needs? Because the hospital's job is really to keep somebody safe. So if I was going into a call and somebody was suicidal and they had passive thoughts, there was not really a plan, there was no history, it was more of a situational crisis, I could really sit down with the person and talk about that. So, we could figure out a plan with them that would be much better than dropping off at the hospital, maybe talking to somebody, maybe not, and then going home. So we do numerous kinds of calls. We know right now that, a lot of people call 911 on people who use substances that are walking down the street swaying. And they call 911 and say, there's something wrong with this person. And if we see that kind of call as the mental health and addictions truck, we'll just go to that call and talk to the person. They did not call 911 themselves. They did not want an ambulance. But at that point, we do have water in our truck or granola bars or something that just says, listen, if you do feel like you do need something, we are there to help, or at least make those kind of referrals. So we still go to a lot of those calls when there's not really a patient, but it's probably better us showing up than an ambulance showing up for that call. So, I'm going to give you a couple examples of how this truck has worked. There's hundreds, there's probably thousands of stories that I could tell you. And I think the work really feels good when somebody has got something that they're not used to getting. So they now know that if they're in a crisis, they can call COAST or a distress line or go to walk-in counseling, or we are connected to all of the community resources that are out there. And we work with some more than others, but we're connected. So we have those pathways that maybe, you're not going to get from somewhere else. So not too long ago, actually, me and my partner went to a call that we actually put ourselves on because it didn't come in as a mental health call, but it looked like it was a mental health call. I think it came in as not alert. It was a 42-year-old male who was in his backyard. And he did have a violent history. It did say that in the details. And, sometimes we do wait for police just to make sure that, there's not a safety issue for me or my partner. We got to the call and the fellow was sitting out back, and, he was also somebody who used substances. And earlier on that day, he did use crystal meth. It had been 4 or 5 hours since then, but he was sitting on the other end of the picnic table. He did have a brain injury as well as some mental health issues. And when the police walked in, he just freaked out. I don't want police, get the hell away from me. It's, and he was screaming. And the police are usually really good knowing when we're coming in, like the mental health nurse is coming in. So I said, listen, just give me some time with them. And they really backed up to the fence as far as they could. I was on the other side of the picnic table because I'm also well aware of my own safety. And the call that had come in, also this fellow had told somebody that he's going to kill somebody with a gun. And, you know, I started talking to him. I said, listen, I am a mental health nurse. And he said, no, you're not. You're a police officer. You're a police officer. And I have nurse written on my shirt, thank goodness. And it's on the back too. So I eventually told him I am not. I'm really here to find out how I can help you. Like, a call came in. It did not come from him, but it was obvious that he was in a crisis situation. And, you know, he agreed to talk to me, and I find out information like, you know, he's food insecure, and his housing is not secure either. People that live in the house, there's some hostility with people that live in the house that he lives in. He does have a mental health history, and he had a recent hospital inpatient stay for 3 days. And when he left without medications. So now he's been 3 days without medications, which is contributing to some of the way he's feeling. And, you know, obviously I have to assess, is this guy really going to kill somebody? So I asked him outright. And of course he said to me, listen, I just said that because I'm trying to get somebody's attention. Like, I just want some help and I don't know where else to go. And me and him, really, it's about me coming up with a plan from where the person's at. At that point, I determined, listen, hospital is not the place for this guy. He just had a recent discharge. Felt like when he was in the hospital, he was treated like an animal, but he does need medications and he knew who his doctor was. It was very easy for me to pick up my phone and call the doctor's office. The doctor's office was not aware that he left the hospital without medication. And very quickly, because they did have the hospital discharge, they faxed the medication to his pharmacy, which was not far from him. He was willing to go get the medication himself. If he wasn't, we would have had no problem going to pick up that medication for him if that was a barrier to him getting well. You know, we also hooked him up with Southridge Shelter. So he was housed at the time, but they do have some outreach workers that are willing to work with people to find housing. You know, I'm sure you guys are not in, are probably in a similar situation to us with homeless and underhoused people or not housed people. It's running rampant. So for somebody to leave the housing that they have, there is no more housing for them to go to. Hold on, I just want to read this. Okay. Anyways, the end of the call, you know, the police were able to leave thinking if they would have went on their own, they just would have taken this guy to the hospital. He ended up with his medication. He ended up with a worker that was willing to come out. We did call community cares around the food bank, which he also was able to go to, even though he went one other time the month, maybe not within the time. But, you know, when we left that call, I really felt like we showed up to something that started as an emergency and ended up to be somebody who really just needed somebody to help navigate obstacles that he couldn't do himself. So he got the help that he needed. He didn't have to go to the hospital. Police did not have to apprehend him. And, you know, and we walked away from the call. He got what he needed. And I think he got the right response the first time to the 911 call that came in.
Perfect.
Thank you so much for this presentation, for these stories. I think it really helps make it sort of real when we hear about these teams like in action, working in the community and seeing what you can accomplish, you know, when you look at a problem sort of from a different perspective and see how you can do better. This has been incredible. I want to make sure that we have enough time for some of the questions that have come up. But before we do, I just want to say thank you so much to both of you, Marty, and to you, Leanne, for being here today with us. And yeah, let's get to some of these questions. So I just want to remind everyone that's watching that you'll find the Q&A icon at the bottom of your Zoom screen, and you can click on that icon to access the Q&A window where you'll be able to type in your questions. We're very lucky to have a large audience with us today, and we are so appreciative of everyone's wanting to participate in this really important dialogue. We'll do our best to get to as many questions as possible. I will be combining questions if they have a similar theme. Unfortunately, I'm not always able to ask each question verbatim, but we will do our best. To lead off our Q&A, we do have a question from our sponsor agencies. And so I want to ask Marty and Leanne, both of you, how has this model been culturally adapted? Have you sought to incorporate or seek out the feedback to culturally inform the responses and better serve Black and Indigenous communities?
I'll start and then I'll pass it over to Leanne for some of her thoughts. When we first started the system transformation journey, let's call it within Niagara EMS, we created a stakeholder advisory committee. And on that committee had representation from numerous agencies and people with lived experience to help with the formation of these teams. So there was representation from various agencies, from Indigenous organizations, community health centers, family health teams that serve these clients on a daily basis to ensure that the teams we were forming had a culturally appropriate lens to them. Now that's at program onset, but it can't stop there. Once you have these teams going, you have staff turnover all the time, you have new people joining the teams, you got to make sure that there's training and education to the staff ongoing. So I know Leanne has a few examples to share about how our MHR team in particular has engaged with some of the friendship centers to keep learning about Indigenous issues.
Thanks, Marty, for that. You know, that's a really good question. I do come from a nursing background, so I understand the importance of at least some knowledge and skill base around culturally sensitive issues, more particular around Indigenous and people of color. You know, I do participate in the trainings. I also recognize my white privilege. I do try and meet people where they're at. And, you know, my question really goes out to who I'm working for is how can I better serve you? Because I understand, even though, you know, it's an Indigenous person, their needs are their needs. And I have worked with some of the friendship centers with some of the clients or patients that I've worked with. You know, the answer to the question, I think, is complex because of the nature of who our patients are, where they are. I understand their experience with hospital, with some other community agencies, you know, and I don't want to say, because I really try and come in to help people overcome obstacles that they can't overcome themselves. So if there's a way that I can help, that's really what I try and do, knowing where the history is, what's happening right now in some of the climate, and being understanding to that. So I think that's about the best I can answer the question.
Another part I'll just add is one thing Leanne and her team do really well is building trust and relationships with the community they serve. So whether it's a Black community, Indigenous community, various other marginalized communities across the Niagara region. She mentioned the homeless as another one. It's key to building trust. And that's why in that initial photo, you saw her not wearing the uniform, because we thought, well, they need to be plain clothes or we're going to have this stigma. Now you see her wearing the uniform because it's about her. Like, we're trying to reframe almost the uniform to not have that stigma. We're here to help you, right? So rather than see the uniform as a barrier, how can we see it as someone you can trust? We want you to come to us when you have issues, and we'll help you regardless.
And this is really great that you've mentioned this, the point about trust. I really liked that quote that you had at the beginning about, inviting the public to trust you as an organization to take care of them. We've actually have a couple of questions about the uniform. So you kind of mentioned that initially you didn't use the uniform and that now you sort of transitioned. I know that there are some other programs, that we've seen, some other models that use uniforms or don't. So, what was sort of the process around figuring out how and what would work best for the community?
Yeah, Leanne, maybe you want to speak to the history a bit more, because I
Yeah.
touched on it a bit, but I know you started plain clothes.
Yeah. So I think when we did start, and it really was my idea around not having the uniform, because the uniform really represents power. And that is not where we wanted to come from. I think what happened after the first year is that I started to understand that no matter who the client is, when they see EMS, they invite them in. Like, being a paramedic really really broke down some of the barriers right away, because they knew they were there to help. Part of the problem is I still do look like a police officer sometimes, like the dark blue, the military. But when people find out that we are paramedics, or they think I'm a paramedic, even though I'm a nurse, it's more inviting. It's not, we did not see that the plain clothes, we needed to have plain clothes. That we were really, yes, it does look like it's kind of powerful. But when we meet people in a uniform and explain to them that we're EMS, it's really—
I think in the winter, you stand out a bit more too, because you have the fluorescent yellow. And I think that really identifies EMS. You're right, the blue is a bit more tougher to discern, but yellow stands out.
Mm-hmm.
That's so interesting. So we do have a couple of more questions. So one of the questions we had was regarding sourcing employees from the communities that are more at risk and that you're serving. So, do you have anything to say about this type of targeted recruitment within the service, so that, your ranks are reflecting some of those communities that you're having to go into?
Well, I'll speak a bit to the paramedic side. Maybe Leanne could speak about mental health nurses. We're suffering a really severe health human resource shortage right now in Niagara. Maybe this is province-wide, with whether it's paramedics, nurses. We're struggling to get people to fill the spots we currently have. So yes, targeted recruitment, hugely important. I believe in that. You need to reflect the populations you're trying to serve. But to everyone on the call, if you got any sons or daughters that want to be paramedics, we have severe shortage even on our ambulances right now, right? Just to fill the core shifts to fulfill our primary mandate. And I've heard the hospitals are having this issue too, losing nurses in the EDs. A lot of this might be pandemic driven, but over the past year and a half, due to burnout, due to fatigue, overwork, overstressed, the whole healthcare field in Niagara is struggling. So yes, I agree with you. We do need to do targeted recruitment, but right now we're doing a second recruit this fall. We typically only do one a year. We're doing 2 this year just because we have such a need for staff, period. Leanne, I don't know if in the mental health nursing field, you're seeing similar issues around staffing.
Of course, in nursing.
Period.
But I know with regards to doing something like EMS and nursing, EMS kind of took community agencies who were willing to give time, because this is a collaboration like no other. Niagara EMS does not pay my wage. Welland McMaster Family Health Team pays my wage. And Niagara Health System pays the wage of another nurse who's on this truck 7 days a week. So it really, and it wasn't, Niagara EMS went out to say, who is interested in this collaboration? So that becomes a little more difficult with us not working for Niagara EMS, because we work for agencies that are just in this collaboration. But of course, targeting people in different populations to come and do this job would be spectacular.
Yes.
We have another question, kind of similar, but related to, during that 911 call and with referrals. So for example, during a 911 call, are people at the other end of the line, are they able to request that one of your teams show up, or does it have to be, is that call sort of made by dispatch?
Yeah, it's filtered through dispatch. They have a triage program called MPDS where they, based on various determinants, decide where the call goes. And I think, Leanne, you participate as part of that clinical response plan development. But that has evolved over time, because Leanne mentioned when the teams first formed, you were not dispatched. You kind of listened to the call details and would essentially jump on calls and call off the ambulance. But over time, we learned through the data which calls each team made the best impact on. And I think you've kind of learned these ones, keep sending them to us. These ones, no, we're not able to make much of an impact there. So it's been kind of an evolution. I don't know if you want to add to that at all, Leanne.
Well, I think some agencies, as well as police, they do try, they say, listen, MHR would be good for this call. The problem is, because it is a 911 response, we may be on another call. So if a call comes into 911 and we're not available, there's only one of us.
Okay.
And that's why dispatch has that bird's eye view of our resources. So they already know who's available and who's not.
So I love it. So it sounds like there's a lot of collaboration between not only your teams themselves, but then also with the community partners. So this actually leads into the next question. So we have a question regarding the MHR teams to population ratio. So in other words, how many teams would you need in order to serve a city of approximately 1 million?
Wow. I know right now the majority of our calls are happening in our larger urban centers, and that would be St. Catharines and Niagara Falls, perhaps Welland as well. We recently did trial a temporary second MHR team just to look at, could we better serve even the southern half of the region, because it's less densely populated, say Fort Erie, Port Colborne, and based on response times, if we're always kind of hovering in the northern half of the region, it does make it harder to meet the time requirements to get to the southern half if you're always needed in one part. So just for geographic diversity, we've talked about having multiple teams based on Niagara being a broad geographical region. But I mean, one is what we have the funding for right now. Our plan is to expand longer term. We've also talked about the hours. Right now we cover 12 hours a day. There's been a discussion, would it make sense to have 24-hour-a-day coverage? Because we do have ambulances working 24/7. The challenge there is mental health resource availability aside from the hospital, right? If you were to have a 24/7 MHR car, who are they referring to at 3 a.m.? Aside from the hospital EDs, there's not many other services open. On the ground, Leanne, do you have any feedback on, if you had your dream, how many MHR teams do you think would we need?
Well, listen, I can tell you, last week, me and my partner in a 12-hour shift did 8 calls. The next day we did 2 calls. So it's really difficult to say, you know, how many calls. We also do have, you know, the police with the crisis worker also working one other truck in the community. So technically in Niagara, there would be 3 vehicles responding to 911 for 12 hours each. 2 from police, 1 from EMS.
Okay.
And that's we're a region of about 450,000 people.
Okay. We have another question. We just have a few more minutes, so I want to try and get to some of these. What are some of the follow-up practices in place for people after they've had a mental health crisis call? So, you know, your team comes in, and then, you know, what kind of linkages are there, you know, post call?
You want to talk about the referrals, Leanne, how that works?
So it all depends. Sometimes people who call 911, they're already hooked up. They belong to the ACT team. I call the ACT psychiatrist. There's been a 911 call. This is what's happened. And of course, this is all with consent from the patient. And what is the follow-up? You'll see them tomorrow at 5 o'clock. I tell the patient, listen, a worker will be here tomorrow at 5 o'clock. Is that good? We rarely leave a call without giving the crisis line, saying, listen, Coast is there 24 hours a day. If you need to talk to somebody in crisis, call them. Other times I'll say, listen, how would you feel about me calling Coast? And they're going to call you today at 7 o'clock, because I know the likelihood of them calling Coast is slim to none. If they say yes, I'll call Coast, give all of the information, give the history of what happened with the call with consent of the patient. They will call the patient at 7 o'clock. Other times I've called doctor's offices. You have an appointment tomorrow at 3 o'clock with your family doctor. You have an appointment on Wednesday. Now, whether or not they show up to those calls, we are, you know, still a 911 response. So we can't, I don't know whether or not they've showed up to the appointment at the psychiatrist, but we never leave without doing something.
It's an important point she made. We don't do case management. So that's kind of a distinction, because we know there's mental health agencies that do that in the community. So our job is to refer to them for follow-up, and then we're on to the next call, as Leanne mentioned.
Excellent. We've got time for one last question. You may have gone over this in the slide deck earlier, but we did have the question. So for those who might have missed it, how long did it take for you to implement this program, get all the partners on board, you know, do all of your research and evidence-based findings, and then roll it out? How long?
Yeah, we started in, I think, 2017. What happened was we had one of our management team here seconded as a system transformation lead. And she was given full time to really work on building this model, because there was so much behind the scenes planning with stakeholder engagement, pulling all of the partners together. As Leanne mentioned, it's a partnership with MHR, so getting all those other agencies to buy in. Forming that stakeholder advisory committee was key, because that involved a number of partners coming together. It reminds me of the quote, if you want to go fast, go alone. If you want to go far, go together. It involved us going together as a community, but I would say you got to invest at least a year or 2 years in that planning element. And then they finally launched in 2018. And I think even with all that planning, Leanne, I think the beginning was still, what are we doing here? There's still a little bit of wild, wild west, even after those 2 years of planning, but being comfortable in the ambiguity and being comfortable not knowing and learning, like that commitment to learning was, I think, what we were looking for in the staff, and Leanne's a perfect embodiment of that.
Leanne, any final thoughts?
No, listen, it really is a pleasure to work with people who have mental health issues differently than what we're traditionally used to doing. Because I think if we don't start to recognize that what we've been doing for so many years is not working, it is not patient-centered. It is not client-centered. It's really based on a system that doesn't work well. So we're really trying to work outside of what we're used to doing. And I think patient engagement or client engagement, or that has been out of this world. People love the fact that it's not the same as it's always been, and they're finally getting the help they're looking for.
Oh, that's a wonderful note to end on today. Our time is coming to a close, but I do want to say miigwech, merci beaucoup, and thank you to everyone for participating today. I want to thank Marty and Leanne very, very much for being here with us and sharing all of your insight and you know, innovation, really. I mean, that's what you guys have done, is you've really sort of co-designed a place where people can tell their stories and get the supports that they need. And that's really what it's all about. So thank you again. I want to thank everyone who joined us online today for taking time out of your busy day to learn a little something new and to spend it with us. I want to encourage everyone to complete the electronic survey that will show up in your web browser once you've closed out of the webinar. And I also want to encourage everyone to join us again on September 29th, when the lovely Jacqueline Saint-Laurent will be here facilitating the session with psychiatric survivors of Ottawa and their Recovery Connections program. So thank you so much to everyone today. Thank you, Marty. Thank you, Leanne, and have a great afternoon, everyone.